So welcome everybody to this meeting of Highland Health and Social Care Committee. Before we start the formal agenda, I just wanted to highlight two things. One, some of you may have noticed a change to the format of some of our papers today and some of the asks of the committee in the agenda, with reference specifically in a number of reports and agenda items to the level of assurance that the committee is being asked to take from the paper. So this refers to some improvements that the board is introducing to its assurance framework. And we were hoping to have been able to introduce this right across the board at the one time, but we're rolling it out across various committees in an informal way at the moment. We will be having, once we're out of governance light mode, at some point a development session on this new way of working, so that we can get everybody up to speed with what we mean by assurance and the implications of the different levels of assurance that people are proposing, which we have a matrix of guidance on that, running from substantial to none at all. So it was just to let you know that the background to these changes that you may have picked up from the papers, and that we will be doing some development with the committee to get everybody up to speed with what that's about and any implications for how the committee works. Okay, and secondly, I just want to also invite Louise to say a few introductory remarks, just to set a bit of context for the committee and in terms of the organisational pressures that the whole health and social care system is experiencing at the moment. Louise?
Just the moment in the UK.
Louise, I'm sorry, but I'm afraid Louise, I'm sorry, I'm afraid your technology is letting you down. We can't really hear you at all.
Okay.
So I don't know if you want to try going out and coming in again, or turn off your camera maybe. Okay, while Louise is doing that, we'll just do the formalities under item 1. Stephen, do you have any apologies?
Yes, got apologies for Katria and the Sinclair, Tara French, Linda Monroe and Boyd Robertson, and Kate Dunnigan and Murray Wiley have noted that they'll be late to the meeting. Okay, fine, thanks very much. So as usual, I just draw your attention to the fact that the meeting is being webcast through MF Teams, and to remind everybody to use the hand function if you want to ask a question, and only to use the chat for alerting me to if I don't see your hand or if you're leaving or joining the meeting, and not to use the chat function for making comments or asking questions. Thank you very much. Are there any declarations of interest today? Okay, I don't see any hands going up. Okay, so in that case then, back to you, Louise.
Thank you, and apologies, just at the inopportune moment my technology failed. Can you hear me okay now?
Yep, that's great, thanks.
Brilliant. Okay, so it was really just to express what a challenge the last 2-3 months have been for health and social care, probably nationally, but certainly as it feels in Highland, it has been a really, really exceptionally difficult time. And I wanted to give that context really on when working through the reports today, just to give you that feel and understanding of the pressures that services are under. I think it would have been difficult enough if we hadn't had virtually 2 years of challenge anyway, but certainly the Omicron, although on the face of it, it feels like it has that less severe impact on people physically, on services, it's been enormous. And the reason I came into the meeting literally from a systems pressures meeting that we've been having and we are now having daily, because the number of staff we have off with Omicron unable to come to work it feels as bad as things have felt for quite a while. And certainly we are looking at putting in measures to support services that we haven't necessarily even had to at any point. We've had some real challenges in care homes in recent times. That's moved to the hospitals at the moment. So certainly within Raidmore, within New Craigs, we've had outbreaks, we've got staffing challenges and pressures. So it does feel very difficult and staff are tired. So I just wanted to not start the meeting on a gloomy note, but just to put the context of where we are. We've in our systems pressure meeting, we were saying this won't necessarily feel like it's forever, but it does feel a little bit like that to people at the moment. So there's a lot of hard work going on in the background. Equally want to give the assurance that everything is being done to ensure that wards are staffed safely, that care homes are staffed safely, but it's difficult. So I think that was just the backdrop. And if I could also mention that there was due to be a paper from Arlene on the agenda. She's been hit by COVID. She's happy for me to let you know that she's not terribly well this week, so she won't be with us either. And that just gives an example. She's been working exceptionally hard the last 2 weeks, keeping New Craig's head above water because they've had some significant outbreaks there. And now she's a victim of the same element that has afflicted our staff. So it was just to give you that picture, really. So hopefully the rest of the meeting will be a bit more cheery.
Okay, thanks, Louise. So if anybody has any specific questions as a result of that context, perhaps we could pick those up at the Chief Officer's report. And just to clarify, unfortunately, because of Arlene's absence, we won't be discussing the Learning Disability Report today. Arlene was due to give us a presentation to add to that report, and really she is best placed to answer any questions and guide our response to it. So it would not be a productive discussion without Arlene present, so I'm afraid we're having to delay that item on the agenda. Okay, so with that then I'll turn to Elaine. Do you want to introduce the finance paper?
Yeah, happy to do that, Anne. I'm not sure whether or not me following up Louise saying that the rest of the meeting would be better news is actually a good thing or not, but we'll see what we can do. So firstly, I'll go through the overall NHS Highland position at month 10, then cover the Highland Health and Social Care Partnership position before moving on to savings delivery and the current position with regards to 2022, 2023 and beyond. So at the end of month 10, NHS Highland is reporting an overspend of 10.792 million and is forecast that this will increase to 16.294 million by the end of the financial year. However, as we've spoken about at previous meetings, Scottish Government have confirmed that funding will be provided to all boards to enable in-year budget balance to be delivered for 2021-2022. So we received details of this funding package at the very end of last week. The package covers all COVID costs, savings slippage, and there's also additional funding built in to fund a number of other areas. And we're in discussion around utilisation and treatment of this funding at financial year end. Obviously, with it coming in so close to year end, we don't have the flexibility that IJBs do, where we can take some elements of funding to reserves and carry it forward to the future financial years. Scottish Government obviously recognise that, and they are working with us to put solutions in place to allow us the same level of flexibility without actually having the reserve option in place. So forecast overspend includes slippage on the board-wide cost improvement programme of £10.69 million. And I think the slippage on the cost improvement programme is a reflection of the other pressures within the whole system, and we've not been able to focus just as much time on some of the cost improvement activities that we would like to, or we would have expected to have done over the course of the last 10 months. So over the same period, the Highland Health and Social Care Partnership's reporting an overspend of 1.604 million, and it's forecast that this will move to an underspend of £658,000 by the 31st of March, with that position reflecting the receipt of additional income for adult social care, and that's actually offsetting an operational overspend of 192,000. So it's an improved position from what was reported to committee at the end of month 8. Reflects additional vacancies. Also, I think as we've gone through the year, we've maybe had a little bit of optimism about being able to recruit, which as times went on hasn't actually came to fruition. And we've also applied some of the winter adult social care funding to bring that position down from between month 8 and month 10. So the breakdown across health and adult social care shows a forecast underspend of 1.12 million within health. So that continues to be driven by a number of vacancies across all services, and there's an overspend of 464,000 within adult social care. The operational overspend continues to be driven by FME services and higher costs of care packages. And I'm pleased to report that the business case for FME services has now been improved by the board's investment board, and that will remove that pressure for forthcoming financial years. So moving to look at the adult social care savings programme, it's forecast that we will deliver the full target of £3 million by the end of the year. And finally, looking forward to 2022, 2023 and beyond, a finalised funding solution for next year has not yet been fully agreed, but that's down to the uncertainty about adult social care funding over this financial year and moving into next year as well. Now that we've got the details of the funding package, we are working through just how this will impact, but it is envisaged that a savings programme of £3 million will be established, and the balance of the £13.3 million gap will come from additional Scottish Government funding either received this financial year or anticipated for 2022-2023. For future years, we are still anticipating a significant gap in funding, and that will be worked through as we come through the next financial year. So happy to take any questions on that.
Okay, thanks, Elaine. Just a couple of things. I think you mentioned that the service pressures due to COVID and the general uncertainty has meant that we weren't able to deliver or prioritise our savings activities as much as we would have liked. I just want to reiterate again, I think it's fairly remarkable that we've managed to achieve the level of savings that we have done despite the pandemic. I think it's important that we remind ourselves that actually there's been an excellent performance in managing to maintain our PMO activities despite the pandemic. And before I move to questions, I just want to ask Louise. Louise, do you want to perhaps update us on what the situation is as regards addressing any future gap on adult social care, and what the status is of the transformation activities with the Joint Project Board, just so that people are aware that there is discussion around that?
Yeah, absolutely. We've got the Joint Monitoring Committee in just over a couple of weeks' time, and we will be taking a paper there with a proposal for where we go with the future, and that will include the monetary position as well as the transformation change. So the plan is for that to go and hopefully be approved there, and we'll be able to report back in more detail at the next meeting and have a further discussion.
Okay, can I just ask, Elaine, before I open it up, you said that with the 3 million savings next year's likely to be covered, but there's likely to be a gap in future years. Is that because some of the additional monies are non-recurring, or is that because we anticipate costs to escalate significantly in future years, or both?
It's a mixture of both, Anne. So next year, the gap that we identified was 13.3 million. So we anticipate that £3 million of that will come from savings, and the balance will come from funding that we've received this financial year that we're not able to use. We are in discussion with Scottish Government about almost handing it back to them for them to give us next year. And they're aware that we're proposing to use that to fund part of the adult social care gap. There's also significant new funding coming in 2022-2023 that we know we won't be fully committing for the intended purpose from Scottish Government, but they have said that they will be flexible about how we use that, and one of the ways that we will use that is for bridging that gap. So we do expect that only to be in place for 2022-2023, and as we move into 2023-2024, we'll have further plans developed about how we actually use that money in line with its intended purpose. So there will be developments within the service. We're looking at enhancing care at home packages. There's obviously the implications with the £10.2 and the £10.50 rate increases as well. We've now been made aware that that funding has also got to cover the associated national insurance increase with that as well. So all of these added up means that we don't have the confidence or the certainty that that level of funding will be available to take forward into 2023-2024. So we're assuming that in 2023-2024 we'll be back to the gap that we had been anticipating of roughly in the region of about £15 million.
Okay, thanks. Right, I'll open it up for questions now. Stunned into silence. Okay, I have got a number now, so I think I saw Neil's hand up first, and then I'm going to come to Jerry, then Wendy, and then Philip. So I think probably what I'll do is I'll take a couple of questions and then come back to you, Elaine, and then another couple, okay, and we'll see how we get on. Okay, Neil.
Only a relatively small point in the grand scheme of things, but is paragraph 2.8 of the report, should that read underspend rather than overspend in primary care? It's just that's it.
I'm just going back to the report, Neil, sorry. 2.8, did you say?
Yeah, thanks.
Yes, it should, Neil. Apologies, there's a typo in the paper.
It's just that I'm just used to the simple ways of life, and if it's in black, it's in my pocket.
Yep, absolutely. Apologies.
Okay, oh well, that was relatively straightforward. Okay, was that your question, Neil? Yeah, you're happy. Okay, Jerry.
Thank you, and thanks, Elaine. And your opening narrative has picked up a few of the issues which I wanted to just chat through. Perhaps if we split them into this year and next year is probably is where I want to go, and probably I appreciate that the position, and I'm looking specifically at paragraph 2.5. Well, I think there's reference to a prudent position with further work ongoing to match elements of this overspend funding, blah 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 blah. Is the inference from that the forecast overspend of 2.797 million in adult social care could potentially come down and change your forecast position, and that may well then have a consequential impact on 22-23? So and I think the answer to that is probably yes. So and I totally get that they're probably working through some of the detail. So it'd be useful just to have confirmation of that. I'm hoping a fairly simple question then, and it's looking at paragraph 2.6, and I'm homing in specifically on mental health services, where if I look at table 2, we've got a small, I think it's a small underspend at the moment of about £82,000, moving to an overspend of £800,000 at the end of the year. Now, moving by £900,000 in the space of 2 months does seem to me fairly dramatic. And I just wondered what was the explanation for that. And then moving more into 22-23, and I say I totally appreciate that 21-22, 22-23 discussions with government, what may well happen with testing, etc., is all fairly fluid. But I think what would be incredibly useful as soon as it's available is actually just a fairly simple, what I would call a sources and application statement of funding that's been made available, new funding that's been made available, whether it be in 21-22 or 22-23, and how that is being proposed to be used in 22-23, because I totally get your point, and that probably was the answer to my real question, that we're probably already been very prudent in anticipating slippage, and I think that's a very reasonable way to go forward, because we're not going to recruit in April, we're not going to recruit in May, hopefully we will recruit during the year. So I think it would be useful to get that understanding, because I think for me what is really crucial to understand is, I say, with my old finance director's hat on, I'm delighted to see any gap coming down to zero, and I just love that. But I think it's more important that we understand that any new money coming into the system is not just being soaked up by a pre-existing gap. And that is not to say that's the wrong way forward, but I think we would need to understand that. But I don't think that's what you're saying. I think what you're actually saying is we're planning for slippage. So it would be good to understand what services we're planning to bring online and when, so we can actually start to understand the impact of those, and that will move us back towards the 23-24 position, where, as you say, we're probably moving back towards somewhere between 10 and 15 million pounds recurring gap. So those are, and I was saying delighted to hear the news on the FME. So those are my issues. Thank you.
You want me just to come back then, Anne?
Yeah, I think just before you do, Elaine, can I just add to what Jerry said there, because I think I would, I suppose, strongly agree that for me, the crucial thing here is going to be the committee being assured that in next year we are spending the money in the best way possible to, address the transformation issues that will be necessary to then be able to reduce any gap in future years. So I just wanted to emphasise how important I think the committee being aware of how we're going to manage to do that would be really helpful. But okay, so if you want to come back on anything that Jerry said there now, Elaine, thanks.
Yeah, okay, thanks, Anne. Yeah, Jerry, you're absolutely right. Anything that we apply this year from funding that we've received will have a knock-on impact in next year. So the more we draw down from this year's funding, the less we'll have to carry forward next year, and that will impact on not the gap, but how we actually bridge that gap and what sort of agreement we need to come to with Highland Council. On the mental health element, I think you've used the word prudent, and I think we are still probably using that prudent on the side of being optimistic around recruitment in the next couple of months. But mental health's also carrying that pressure that we've still got over the FME services as well, so that will impact in February and March. Interested on your slow season application statement, and I suppose it's not a phrase that I've heard, but it is something that we are actually looking at doing and just seeing when we will be factoring in the funding that we've got coming through. For those of you that were at the Financial Resource and Performance Committee last week, I did mention that we'd had 55 additional allocations coming through in December, January and February. So that's a significant amount of additional funding that's come through. And it's obviously all come through at the time where everybody's focus has really been dealing with Omicron. So we're probably not as ahead of the game as we should be in terms of getting plans in place, getting recruitment in place for a lot of these funding coming through. So that is recognised by government, and that's why we're being allowed that flexibility to actually give them funding back and carry it into next financial year. But I can certainly look at what's coming in for next year, and we can work through what we're likely to do with that and bring something back to a future meeting of the committee.
Okay, well, I'm sure that would be much appreciated, Elaine. Perhaps we can note that as an action for the going forward. So can I come to Wendy and then Philip? Wendy, do you still have your hand up? It's difficult for me to see, I'm afraid. Sorry, Wendy, we're not hearing anything from you at the moment. You're muted.
Sorry, everyone. Hi, good afternoon. I just wanted to clarify what the question that Neil had asked. So, is it an overspend or an underspend that was highlighted? My question comes in two parts, really. What considerations are taken into account when there's any savings being made, and is there any particular reason that that social care take that hit?
Okay, so I think Elaine has already clarified that there was a typo in at 2.8.
Yes, so primary care it should be underspend.
Okay, so do you want to address Wendy's second question then in relation to the savings requirement in adult social care?
Yeah, I'm not sure I necessarily followed it all through, Wendy. I suppose overall there's a £32.9 million savings plan for NHS Highlands, and of that £3 million was within adult social care. Quite a high target, but I suppose we're setting that against the £11.3 million funding gap that was identified. So there were a number of work streams set up, but again, because of the pressures that the whole system's been under, all of those savings this year have come from one work stream. So that one work stream, so the residential transformation and adult social care cost improvement programme. I think once we've worked through a good bit of the year in the detail within the other work streams, I think the view was that they're likely to be more transformational, so we'll have that longer time frame to actually deliver savings.
So if I could just add to that, Wendy, the savings requirements for adult social care have been monitored or overseen by the Joint Project Board with the Council during the last year, and we follow a process that the Health Board has developed for its PMO in terms of any savings proposals that come forward from staff are scrutinised and have to meet a certain challenge in terms of issues of quality and safety and impact of the proposals that come forward. So I just wanted to make it clear that there is, a level of scrutiny of proposals that come forward around any of our savings, and that they are all assessed for quality, patient safety and impact. Okay, do you want to come back on any of that, Wendy, or are you clear about the position?
I'm much more clear now. Thank you for that.
Okay, great. Philip?
Yeah, just a quick question. Delighted to see that the business case for the FME has been approved, and I was just wondering what progress has been made on the recruitment and when we can expect that position to be filled.
Probably the honest answer is we haven't made any progress yet, Philip, on recruitment, because the business case has just been approved. So we're working through a number of approvals that have come through. Louise might be able to give it an update. I see she's put her hand down, but hand up. So we are working through just the outcomes of all the business cases. So it is just almost within the last week or two that it's been approved.
Sorry, Louise,
you're on
do you
mute,
want to come in?
But yeah, I could read. That's what you said, Louise. So I'll come in. Yeah, we're still in the process of recruiting to the clinical posts, currently still running on agency for most of those. However, we had already preempted the fact that we knew this was in the pipeline, so we have got a manager for the service and we have got administrative roles, etc. So there's some infrastructure there. We've got a head of service, our head of drug and alcohol services manages the service too. So we've got that bones of a service in order to bring forward the things that we need to do around clinical recruitment.
Okay, can I just double check while we're talking about this, Elaine? The appendix with the broken down detail of the budget. Is the police custody service what is represented by the overspend in drug and alcohol?
Yeah, that's exactly it, Anne.
Right, I just wanted to double check that's what it was. Okay, actually, Michael, given we're talking about this service at the moment, do you want to ask your question or raise your point about from the minute of the meeting about the naming of the service?
Yeah, thanks. Yeah, I remember at the last meeting we had a bit of a discussion about this, and I just wondered if anything had sort of been discussed with the meeting or in regard to the naming of this service.
So I don't know, Louise, if you remember, but it's in the assurance report that I think there was general agreement that we needed to find a more positive name for the service. So I think it's just asking for assurance that somebody that's been fed back to those responsible for it, and
yes,
somebody's looking at it.
Yeah, absolutely. We've fed that back and the service are exploring what would be the best route to take.
Okay. Well, perhaps we could note to come back and update us on that in the future when some proposals have been put together. Neil, do you want to come back in?
Sorry, yeah, just a couple of points. First off, to Philip, just a little bit of soft intelligence. I do know of colleagues who are seeking qualification and training in the forensic side locally, so you can be a little bit assured there. That's number one. Point two was the impact on quality patient care. There's a paragraph 3.1 mentions a tool which can be accessed from the Programme Management Office. I wondered how available that was. I wouldn't mind being able to see it.
Yeah, I will see what I can do, Neil, to bring something back.
That'd be brilliant. Thank you.
Okay, I don't see any other hands up. Oh, wait a minute. Don't think there's anybody else looking to come in at the moment. Okay, so I think, Elaine, it was helpful to hear just your further context, and I think the main message that we want to take away from the meeting today is that it would be useful to have some more information at the April meeting about, hopefully the picture will be clearer, and so that we're able to see what's flowing in and what's flowing out, and also more detail about how we're proposing to go forward in addressing the adult social care gap in the future, and how we're going to use the slippage and flexibilities to best effect in the coming year to address that issue going forward. Are you happy to take those messages away?
That's absolutely fine, Anne. I can bring that back.
Okay, that's great. Thank you very much. So moving on then to our assurance report from the last meeting. Does anybody have any matters of accuracy to raise? Don't see any hands up, so I take it then that we're happy to approve the assurance report. Don't see any dissent, so I'll take that as a yes. I just wanted to add one thing to the information in the rolling action plan, and that was to say that we're arranging a meeting between Louise, myself and Ian Thompson to address the action about future reports to the committee arising from the SDS strategy work. So again, due to pressures, well, there'll probably be a little while before that meeting takes place, but that is in hand. So I just wanted to update you on that. Does anybody have any other matters arising from the last meeting that's not otherwise on the agenda? No, okay, thank you. So in that case then, Tim, I think hopefully I'm handing over to you for the COVID update, which unfortunately doesn't sound like as positive as we might have hoped it would be. Thanks.
Yeah, thanks, Anne. No, it's a little bit, it's certainly a little bit disappointing. Some of the main points have already been covered by Louise at the start of the meeting. The bottom line is that while we did see a very considerable reduction in the cases from the peak around Christmas time and early into January, that then plateaued and really went up, and we're in the rather unusual position at the moment of being one of the worst boards for the level of COVID, more so in the Highland Council area than Argyll and Bute as well. And I think we're about third from in the council areas. Last time looked, we were third from the top, which is an unprecedented place. The reasons for that aren't entirely clear. It could be simply that we've had very little exposure to COVID, not very little. We've had less exposure to COVID than many other areas in the past, and there could be some people who are perhaps less immune and so more likely to pick up COVID now. That could be one reason, and perhaps that combined with a new type of Omicron COVID, which is a bit more infectious than the previous one, which has been spreading for a month or two now. But whatever the reason, the effect is that we're seeing a large number of infections. These are mostly mild, but not in all cases, and we're certainly seeing a rise in the admissions to hospital. The greatest effect of the rise in cases is, as Louise outlined, in terms of staff. A few weeks ago, the biggest grouping of the population affected were teenagers, and particularly young teenagers. But that's gone up the age range a bit, and if you sort of divide the population up and look at the highest group by age and gender now, it's actually women aged 24 to 44. So a lot of those will be in the workforce of health and social care. So that partially explains that. We're also seeing quite a lot of outbreaks. So there's the general effect on staff, but there's also the effect of outbreaks. We've had outbreak at New Craigs. We have cases within the acute hospital sector, and a large number of care homes are affected. The good news, I suppose, is that the effect of vaccination has largely meant that cases are mild. As I said, people are being admitted to hospital, although the numbers are a lot lower and the severity of illness is lower than it's been in the past. But we're still getting the cases, and also what I think we're seeing, and it's a national phenomenon as well, and I suppose not unexpected either, is that people are not taking COVID as seriously as they have done in the past. And while I think the precautions in general terms in the population are better in, certainly in Scotland and in England, I think that's definite, and may well be better in Highland than other parts of Scotland. I think we're seeing outbreaks connected with staff socialising, and I think that the level of care taken is less. I think once people get outbreaks, then they recognise that there's still the need to exercise a great degree of caution. Just to close off, to give an indication of what's happening, the number of cases that we're seeing each day is perhaps the best indicator of what's going on at the moment. And the last figures I saw were about 400 cases a day, 300 to 400. We peaked at 600 most recently. The highest we've been at is just below 1,000 cases a day, although the counting's a bit different. When it was 1,000, that was just PCR tests. Now it's PCR and LFD, so it's not really looking at like with like. So I think the message is we may be going down now, although some of the data collection's not great. So I can't be sure of the latest figures. I could be very, very cautiously optimistic of a little bit of a decline, but the numbers are still very high, and it's having a really big effect on the health and social care system.
Okay, Tim. Could you just say a little bit about where we are as regards vaccinations?
Yes, I mean the main program of vaccination for principal doses and boosters is largely finished. We have in excess of 90% coverage for 2 doses or 3 if necessary, and booster for in each age group over 55. And I can put, you just bear with me, I can demonstrate that. So this, hopefully you can see this slide, which shows the vaccination coverage for the whole of NHS Highland for above 12-year-olds. The darker the colour, the higher the level of vaccinations. The dark blue is people who have the fully vaccinated plus booster. So you can see that even going down to people aged 40, 30, the coverage is very good. We are doing some degree of catch up at the moment, but the vaccination activity, certainly for older people, is not huge now. Where we're moving towards is we're completing the teenage vaccinations, and then moving to the additional dose for vulnerable people, which is people in care homes and people over 75, and also then moving from a vulnerable 5 to 11-year-old population to a comprehensive 5 to 11-year-old population, and those programs will be starting later on in the month.
Okay, thanks very much, Tim. So questions, I'll start with Michael.
Yeah, I've got three parts to this. Following on from what you've just said, obviously come September, everybody usually has over 65 have their flu jab. And obviously, if vulnerable people over 75s are going to have an extra jab in the spring, which I you can correct me if I've got this wrong, is it the intention to give everybody a booster come September that are over 65? And will this be a pill, or will we going to require more boosters this year before we get to September?
Right, yes. Well, there are no pills that are able to take the place of vaccinations. So we will be looking at vaccinations. We can't be certain about the vaccination programme at this stage, but we can be, with a reasonable degree of certainty, we will be looking at another programme of a widespread programme of vaccination using the same vaccine sometime in the autumn, around the same time that people get the flu vaccine. Precisely what age groups it would cover, I'm not sure. It could be everybody over 18, or it could be everybody over 50 or 55. It'll be more extensive than everybody over 75, certainly. But we would anticipate that in autumn. And the evidence does suggest that that the original same vaccine seems to be pretty effective, as effective against the variants as any specifically designed vaccine. So I think we're likely to get a similar programme, uncertain quite what the age cutoff will be at some time in the autumn.
The second part is, as I'm looking out the window now, it's a lovely blue sky and it's nice and sunshiny, is we'll start with getting visitors soon. And then come mid-April, it'll be Easter holidays. And I'm just wondering, as a lot of people in England seem to think that COVID's disappeared, particularly the government, is how we're going to deal with that. And what concerns me is that I understand, and you can correct me if I got this wrong, that you can't obtain a lateral flow device in Durness. And the nearest place you've got is either Ullapool, Lairg or Thurso. Now, Durness has a huge motorhome and caravan site, and a lot of people from England will be coming up to Durness. And obviously there isn't a pharmacy, the nearest one's in Lairg. I'm just wondering how this is going to be handled, coming the holiday season.
Thanks. I mean, I think just around getting a lateral flow test in Durness, residents can get lateral flow tests by post, but clearly that wouldn't be the case for, well, it would be very difficult for tourists to do that. I think in terms of testing, we don't yet know what the position will be for Scotland as a whole for testing later on in the year. England seems to have abandoned largely, so they abandoned free testing for people unless they're at particular vulnerability, and that's really not and that's about eligibility for medication to combat COVID. The funding for testing largely comes from UK government, and so there's a challenge for Scottish government then to decide what the programme will be and how they will wish to continue that. The First Minister is due to make an announcement at some time later on in March. I'd expect sooner rather than later, and we'll need to work out how that what our policy is based on that, on government policy. So if government policy is to continue the availability of testing, or to the extent that we are looking to continue the availability of testing, we need to make sure that that testing is available for visitors as well. But it's difficult to, it's difficult to be more precise about that because I'd just be hypothesising about what the First Minister might say, and we could look at different scenarios, but we don't know which one will happen.
Okay, Michael, do you have a third? Is that?
No, I shoved them together in the last question.
Okay.
Thank you.
In terms of, can I just ask, as a supplementary, just in terms of residents being able to access LFDs by post. Michael, are you, I mean, is that working, do you feel, for your area? I mean, I have done it myself and it was very easy right at the start before they became widely available in Inverness. But
you know, I've got this thing about equality of provision, and I'll be raising it a bit later, is that if you're in Inverness, as I said, the nearest place is either to go to collect one is either Ullapool, Thurso or Leg. You know, and that's a fair distance. Even if you've got a car, it's a fair distance. And I just feel that, you know, does the provision stop at Leg? You know, I mean, it's the same, it's less to extent if you live in Tongue, but I'm just trying to understand, you know, the idea behind all of this.
so, Tim, we've been doing a lot of work recently with with having kits available in, you know, various areas just on a rotating basis. Are we doing anything like that in Northwest Sutherland in terms of arranging drop-offs?
The issue's been highlighted several times before, and clearly it is something that we're concerned about. I'm trying to recall, but I can't quite recall the answer to that. I think that there is some work being done, and the LFD distribution is done through the council rather than through the health board around Northwest Sutherland. The government policy on LFD testing is more around, is moving more towards targeted delivery of LFDs more than around overall population delivery. So we may move to a different position, and it may relate to tourism as well. So we're certainly aware of the issue and are looking at how to at the best way to address that. But it is quite a challenge to get the specific delivery out. And we're using pharmacies as well as postal delivery, and there's some expansion of the fire station service for PCR tests also to our LFDs. But unfortunately, some of the expansion can be a bit uneven, and it can be difficult to get everywhere. But we're certainly aware of the Northwest Sutherland question, and it's been highlighted before, and it's not going to go away. Well, hopefully it go away in provision, but we're not going to forget about it.
Okay, with that clarification, that's helpful. Jerry?
Thank you, Anne. Tim, a very quick question. We've had a significant increase in numbers or deterioration in numbers, whatever way you want to look at it, on Orkney as well. Is there anything specific to the Highlands and Islands which we're seeing at the moment, which is skewing us away from the national positions? And I'm aware Shetland have got increased numbers as well, and I was talking to Gordon Jameson on Western Isles a few weeks ago, and they were similar. Is it just that we've come from a much better place, or do you think it maybe ties in with the earlier point about we're approaching tourist time of year? I'm aware that the first boats are due into Orkney, I think, in the next week or so.
Yeah, I don't think it's the tourists. I think it's probably the former. I mean, it's likely there isn't just one simple explanation. There are probably quite a few things. I reckon the most likely thing is simply that we had fewer people infected in the past. Therefore, the overall population level of immunity from past infection will be lower, and so there are more people who are vulnerable. That would be my best guess. The geographical distribution of where people are getting infected now doesn't entirely bear that out. So I think there is more to it than that. But I think that's probably the most thing. But of course, we do get the benefit now. It might not seem like a benefit now with so many people being infected, but at least people now are being infected when there's a very high level of vaccination, compared with a while ago when there was a lower level of protection from vaccination. So it is beneficial to have it this way round, but it is very difficult at the moment. I suppose the silver lining is that we would expect the numbers to go down fairly soon if the reasons for that are the case. We'll just be following other areas of Scotland, but just a bit later. I suppose it's maybe similar if you look at the comparison between England and Scotland. There was a time only a couple of months ago when England had far higher rates than Scotland, but its rates, the rates in England dropped quicker and dropped first, and then the rates in Scotland started to drop. And I think we will, in some parts of Scotland at least, and I think that we will see some of the rates going down locally and in the islands fairly soon. That's a little bit of optimism bias, but I'm reasonably confident about that.
Okay, thanks, Tim. Anybody else got any questions? Don't see any hands, so I'll ask one then, Tim. I was just wondering, is there any indication yet whether, you know, in the latest wave, there are any differences in terms of the level of impact of long COVID, and how are we doing in terms of establishing services for those people affected? If that's not your bailiwick, then perhaps we could.
Yes, I think in terms of long COVID, I need to come back. I mean, there are services there. I haven't been directly involved in the long COVID services, so I think it's certainly an important area that we need to come back to. And we can certainly come back either outside the meeting or at the next meeting with a more detailed report on what we're doing for long COVID services. I think there are different elements of long COVID. So there are people who have serious effects following hospitalisation and sort of continuing lung disease for a very long time after severe COVID. We're not likely to see as much of that because the current cases admitted to hospital are fewer, and also the level of disease is lower, and there are treatments available which can help to tackle the disease and stop it becoming more severe. The other sort of generic type is a more post-viral illness and long continuation of other COVID type effects. I am not aware of anything particularly pronounced with the recent wave, but I think that we would still we need to be prepared for quite a considerable effect. And what's undeniable is that many people are getting effects of COVID for a long time after the initial infection. So I think we still don't know, but we need to continue the development of the services, and we'll need to come back separately about that because I'm not adequately cited on it.
Okay, so Louise, I just wonder, I mean, obviously what's happened in the last week or so might have changed things, but I guess we were almost getting to a situation with this wave of thinking that matters related to COVID almost had to move into a business as usual sort of format. And I think it would be useful for us to perhaps, in addition to the question I've raised about long COVID services, perhaps do a bit of a report just giving this committee an overview of, you know, what areas of its terms of reference, you know, might relate to COVID going forward. You know, where are the, for example, with the vaccination programme going forward, what specifically, if any, responsibility would this committee have in relation to assurance about delivery of the vaccination programme within our area, that kind of thing. So, I mean, not necessarily immediately, but maybe could we have a chat about that going, you know, just and look at that in terms of the committee's work plan for the coming year?
Yeah, absolutely, and it's probably one that Tim and I can link in on too, because Tim has the public health responsibility and I have the operational responsibility. So between us, we can probably think of the best way from a vaccination point of view, and from that wider COVID position. It may be that actually we ask the teams as they come and talk about their services that there's an element of where are we with COVID. So it becomes business as usual, but we acknowledge that there's still that element, hopefully a small element as we move forward, to take into consideration. So it's all part of our transformation work as well, and our sort of remobilisation.
Okay, I think that would be helpful at an appropriate time. Okay, thank you very much, Tim. That's helpful. Thank you.
Thank you.
Okay, then we're moving on to item 3.5, the Children's Services Report. And we have Sally with us. So, Sally, could I just emphasise that you can take it that we've read the report? So if you could perhaps, because I am aware already that there's a lot of people wanting to ask you questions about it. So I'd like to, you know, give as much time to the questions as I possibly can. So just if you could keep your introduction quite brief. But one of the things, perhaps if you could cover in that introduction, I'd be grateful, is how far we've got in discussing what the content of your report and your proposed approach going forward with the council. You know, whether this is a kind of jointly agreed proposal as to how we move forward, or whether that's still under discussion. So over to you, Sally.
Thank you, Anne, and thanks to the committee for the opportunity to be here today. So I've been working with Tracy Legema on this report, and the opportunity to put a report into this committee, the timescales were quite tight. So it's very much a first iteration of something that's open to being presented in a range of different ways. And while I had background conversations with colleagues who are responsibility for services within the report, it's not formally yet gone through those processes, and so that there's an action there, if you like. I welcome the fact that people have read the report. I don't really need to say that much else other than what we're asking for is a conversation today around what comes back next and where the responsibilities for that sit. We have a language of working to whole systems working. That's particularly important for children and young people. Just thinking about the previous discussion around COVID, undoubtedly children have been impacted, and in different ways, perhaps to adults, and perhaps over a longer period of time. And I'll put a link into the chat just now for people who are interested around Public Health Scotland special interest group around those longer term impacts of COVID. And it ties in with the wider social mitigation work that we've talked about with the board in terms of COVID as well. So maybe Anna, I'll leave it at that if that's okay, and happy to take questions. Thank you.
Okay, well, and thank you, Sally. I think certainly I think this is a very interesting report, and there's a lot of really interesting information in here, and so I'm sure we'll have a good discussion today. Okay, so questions, comments about Sally's report? I know several of you had some, so don't hold back. Well, can I invite, I don't know if, okay, Philip. I'll say, Philip, before you come in, can I just ask, I'm sorry, I can't see who's here from the council from an officer point of view today. Is Jane or Fiona Duncan here today? Is there anything you would, or indeed Tracy, because I saw her, I'm not sure if Tracy's still with us. I know she was having to depart, but would any of the other officers like to say anything before I bring Philip in?
I think Fiona Malcolm's got a hand up.
I have got my hand up, although not in a very helpful way, Chair, because you will know that I'm not terribly sighted on children's services, and I don't think either Jane Park is here and Fiona Duncan certainly isn't. I doubt I'll be in a position to add to anything Sally's got to say. In fact, Sally's probably smiling that I'd even think that I might be able to, but I will for sure take anything back to either Jane and or Fiona if there's anything that Sally herself can't handle. Or sorry, can't handle, doesn't know the answer to, but otherwise I'm not sure I'll be of much help.
Okay, right, thanks Fiona. Sally, do you want to come back in?
Yeah, just for reassurance for Fiona, I did discuss the report with Jane earlier this week, Fiona, so there has been some dialogue within Highland Council around the children's elements that they have responsibility for. Thanks.
Okay, so Philip was first, and then I've got Jerry, and I've also got Joanne. So Philip.
Yeah, thanks, Sally. That's a good report, which has a lot of information, a huge amount of information in it, actually. I was just wanting to go to the section where it talks about the shortfall of CAMHS clinicians. There's an active programme which is ongoing to recruit, I think it's about almost 15 clinicians, and as we constantly hear, there is a problem with recruiting, with the availability of staff. Do we have a contingency plan if we aren't able to recruit in the numbers that we would like? And what's the impact going to be on services, and how do we address that if we don't manage to achieve the numbers that we want?
Okay, so it may be that somebody else other than Sally is better able to respond to that. I don't know. Who wants to pick that up?
So I can start, Anne, if that's okay. So we know there have been consistently workforce pressures in terms of CAMHS across Scotland for some years now. And Louise has oversight and has put her hand up, has responsibility of that through the CAMHS programme board. So maybe I'll suggest Louise comes in now, and then I can pick up afterwards.
Okay, Louise.
Thanks, Sally. Yeah, you're absolutely right. CAMHS is one of our real challenges, and it is around that recruitment, because all the boards were given additional money, which is very welcome, but all the boards are then trying to recruit the same people, and there isn't enough to go around. So it is a big challenge. Contingencies are tricky too, because if you need a clinician, you need a clinician. However, one of the things that we've been exploring is flexibility of roles. If we can't necessarily get all the psychologists we need, can we get advanced nurse practitioners, advanced AHPs, etc. So it's looking at that wider workforce, but also looking at possibilities of people working remotely. So we do more work on near me. So are there opportunities for us to have clinicians that aren't necessarily based in the Highland doing some of this work? And then a third thing that we're really exploring too, is that whole North Highland working. So what can we do with Grampian, what can do with colleagues from other boards in the north to actually try and provide a service that spans all areas, and also looking at different types of things. Is group work appropriate in some cases? Limited in CAMHS, unfortunately, compared to adult services, but there may be options for some things like that, some use of technology, etc. But also there are national CAMHS standards, and it's making sure that we're all of our plans are ambitious enough to meet those standards, but with the flexibility that we may need to look at doing them in a slightly different way to what we would if we had an ideal world scenario.
Okay, can I just ask somebody to answer a technical question about the graphs around CAMHS? Because I think one or two people were having difficulty just understanding. So the scale on the left-hand side of those graphs, is that weeks? Is that weeks, days, patients? Yep, so for example, I'm looking at figure 17 here, and it's telling me presumably that there are 85 people have had an accepted referral for tier 3 services. Is that right? Or so if somebody could just comment on the scales in these graphs and what they mean, please. Sally, can you do that?
And that's a point well raised, and apologies, because I don't have a simple solution for that, so I can email a response out to that. That's probably easiest, rather than endeavouring to understand. I mean, you have yeah, I can't. That's a point well made. I'm not going to waffle any longer. Thanks.
Okay, Louise, can you answer that? Or
I can. So in terms of the numbers, if you look at the accepted referrals, the 85 is the number of people accepted within that month, and the 17 would be those that have been accepted for tier 2. So that is to looking at the referral rates for each of the months. Is that the graph you were referring to, figure 17? Oh, I think you're on mute.
sorry, I think it was really all of them, Louise.
Right. Okay.
But just
So yeah, absolutely. It's the total number of weights, and it's taken at a month point.
okay, right, fine. Okay, thanks. So I think what it would be useful to do would be to round up any other questions on CAMS before we move on to questions about the other items in the report. So does anybody else have any questions that relate to the CAMS aspects of the paper just now? Neil,
Yeah, if I may. Coming back to the point you made, I'd interpreted those numbers as Louise has explained them there. How many consultant clinicians do we have in CAMS currently? So, I thought it was
Louise?
3.
Right, Neil, I don't know the details of exactly how many we've got in post at the moment. I don't actually manage the CAMS service. I've got a responsibility for mental health overall, but it's not one of my services. It sits within acute. So I'm afraid I need to let you know the details out with here.
Sure. The reason I ask is simply because I'm looking at numbers here of 103 accepted referrals. That's an awful lot of individual referrals over 1 month. So I guess my question is going to be, is this statistic true accepted referrals into the system for some work to be done within Phoenix House or remotely? Or is it a referral which is accepted for discussion around a table, which then many of which are bounced back to schools, parents, GPs to have a focused, structured meeting, etc., with a little bit of advice from CAMS? So in other words, I guess what I'm actually asking is, what does accepted referral truly mean?
My understanding is that this is the accepted referrals. However, we are in the process of much more substantially introducing triage assessments, because a lot of this is accepted on paper and it isn't actually accepted following a face-to-face triage appointment. Probably about a quarter to a third at the moment have been having that. So one of the things that we have been putting in is that very much actually seeing people, understanding their issues, rather than them ending up on a waiting list for 6 months, and then when we see them we actually think there's somewhere that we could point them in the right direction for. And that's one of the things we've been talking to Scottish Government about having as one of our priorities on our improvement plan.
Brilliant, thanks.
Sally, did you want to comment on any of those points? Or
Yeah, a couple of things, if that's okay. Recall this is the first iteration of a performance report, and I do think the interest in CAMS is really important. So it might be that we come back and do a focus session around CAMS and have the relevant information and people around the table to comment. We have lots of data around CAMS. I suppose my other point is just to recognise is if a child or a young person is referred into a tier 3 service, then there have undoubtedly been a range of needs prior to that. And the mental health needs of children and young people absolutely require that whole systems approach across the life course, from pre-birth first 1,001 days through to universal early education in childcare, primary schools and secondary schools. So the way we work within that whole system to support and understand the needs of children in the context of the family and how schools can support that is really important. And the other thing to say, over the COVID period, as a result of COVID, we've seen exceptional levels of quite complex and quite late presentations for children and young people, particularly with eating disorders. And that's been an unusual presentation, if you like, and I think is a sharp-end effect of how COVID has impacted very powerfully on family life, on children's mental health and well-being, and alongside the related issues around surveillance at 13 to 15 months and 27 to 30 months means that our whole system working recovery plans around mental health need to have some attention paid to them, and we need to be working that whole system to best effect and not losing sight of the £600,000 of investment in the primary mental health worker service within Highland Council, and how we bring them round the table and are assured that they're supporting and working tightly in the same direction as the Tier 3 CAMS colleagues. Thanks.
Yeah, I think that was one of the things that really struck me about this part of the report was, I suppose, the need for whole system working across a whole range of services, and you know, certainly across the council and education and CAMS, but also I'm sure that, you know, there will be a lot of third sector contribution there as well, and I think it highlighted for me the importance of the decision to develop a very broad strategy under the auspices of the Community Planning Partnership, you know, to help with achieving a whole system approach to this. Can I ask, so Louise, did you want to comment on that, or was it something else?
Yeah, it was just to add to what Sally was saying about the COVID effect. We have actually also seen a significant increase in the urgent and unscheduled care work by CAMS. So a significant number of people that have been referred that cannot wait. We wouldn't want anybody to wait in an ideal world, but certainly those that absolutely need seeing. So there's been quite a diversion of the service to do that work. And one of the things that the CAMS team are looking at is setting up much more of a dedicated team that will focus on those people that have an urgent unscheduled care need, as well as those that are working with the day-to-day workload.
So I can see that Mari has her hand up. Was it this topic you wanted to come in on, Mari, or was it another aspect of the report? If it was another aspect, I'll come back to you once I've been to Jerry.
It links into mental health, and it's not specific about the CAMS service necessarily, but I'm happy to wait till later if you prefer.
Well, if it's on mental health, then come in just now.
I suppose that there's a couple of aspects to it, and I'm not necessarily expecting a specific answer to this. You mentioned about the third sector, and I do think that we do have an issue in terms of the performance measurements tend to focus on what's easier to measure, which is the public sector delivery, and it's how are we actually capturing the value for the third sector contribution is around that. Because what we are getting back anecdotally from the third sector is because of the pressures on the CAM system, more often than not, people are looking to the third sector to fill that space, which is pressurising. But the other thing is we don't actually have as many third sector organisations delivering those services that are specific to children, which require specific types of delivery over and above adult services. You can't just take an adult service and adapt it to put it straight into for children. It's not that straightforward. But what we don't have is an investment plan and commissioning processes around those services for children in relation specifically to mental health. What has been really interesting is with the additional investment through the Mental Health and Wellbeing Communities Fund that the Scottish Government made available, which is now just under £1 million that we've invested out in the last 2 or 3 months. The number of groups that came forward to try and access that for children's services wasn't insubstantial, but the fund was only for over 16s because there is another investment fund that has gone into Highland. Now, I've been asked repeatedly, including by the public sector, where is that? What does that look like? Who's controlling that? I don't have an answer, and I've tried to find that. So how is it that there has been investment into Highland around children's services, around a broader approach than just simply to CAMS, from the best of the information we've got from the Scottish Government, and yet nobody knows about it. And if we don't know about it, how does the third sector have access to develop services that are much earlier intervention and less crisis end? So it's a question out there to some extent, and to say, I think the third sector has capacity. We're definitely seeing anecdotally that there's a demand for this. When the CAM service is unable, because of pressures which we all are aware of, to deliver services, third sector are being left to pick this up. But we're not being told and being included as a partner when investment is made available. So I'll leave that as it stands.
Okay, Sally, do you want to come back on that point, or before I take another question?
A couple of points, Anne, if that's okay. I think, Mary, your points are well made, and part of the challenge around our whole system working is how do we pull those different strands that have come through into the one place and have shared decision making around it. That's an outcome that I would be looking for. We know that young carers, for example, do some invaluable work with more young people with recognised needs. And certainly from my involvement with the Pronate Infant Mental Health work, Home Start continue to do fantastic work and have some additional funding there. We know that there's funding gone into education for school counselling. We need to bring that around the table in relation to the joins with the Prime Mental Health Worker Service as well. So I would be saying there's some urgency to get that whole system working, going, and to be clearer within our partnerships how we align and use that money to best effect. And I'm linked into the work Caithness Cares and the Sutherland work just to understand from a public health point of view what the opportunities are to knit that whole systems framework around that, if you like. Just one last point briefly, going back to data, Anne. The latest data that I've seen over the last couple of days suggests that demand is high. Waits continue to be long, but they're not getting any longer. So there's some vague hope in there, or sense of actually it's not easy, but it's not getting any worse, but the demands and pressures remain. Thank you.
Okay, so I suppose the question for me, Sally, is where is the appropriate place to take a more comprehensive look at this issue about bringing the whole system together in terms of designing the services going forward, whether that be third sector or education or whoever. And you know, I'm pretty sure I just saw an announcement that there's been an extra money put into that fund that Mari mentioned, the Community Mental Health and Wellbeing Fund. So even more resources. You know, to be honest, often at the moment, money doesn't seem to be the problem. It's getting the time to actually work out how to spend the money, and then the people to staff the posts. So my question is, where is the appropriate place to actually develop a response to these important points that are being made? Is that in one of the officer groups? Is that through you know, some future report to this committee? And just you know, when we're thinking about all of that, can I make a plea for whole system to include young people themselves, and to actually see some evidence of engagement with young people in redesigning these services? I'm sure that's going on. Obviously, it's gone on in Caithness to a very productive degree, and I'm sure there are other examples. But personally, I think that's an important strand of the whole system.
Okay, thanks, Anne. So the Integrated Children's Service Board is where we come together as integrated children's service partners. So that's health, the local authority, police, reporter, third sector. That group links into the Community Planning Board, and alongside the Community Planning Board is a themed priority around mental health. So it's quite a busy landscape, actually. Alongside that is an interest expressed by our Chief Exec and Donna Manson in the local authority for exactly that whole systems approach. Quite the nature and purpose of that isn't entirely clear just yet, but it will come, and I think the discussion today is part of how that is framed and what then follows. We do have mental health as a priority within the current integrated children's service plan, but the knitting of the different strands together, bringing the cultures and the practices and genuinely making it integrated is where the challenge lies, I think. but many opportunities. And just coming back to the impact of, and it says it in the report, self-isolation measures, schools not being open, hothouse family systems has been impactful on children and young people, and it should be and needs to be a priority across levels of need. Thanks.
Okay, so I'm going to go around the remaining questioners and then come back to you, Sally. I'm just conscious of time, and I think that would be the most productive way to do things. So I'm going to go to Joanne first, and then Jerry, and then Michael, and then we'll come back to Sally to wrap up this discussion and turn to the specific questions that she's asked us in the report. So Joanne.
Thanks, Anne. Just a couple of points. One of them is more a kind of observation over the report in general. There's a terminology of ongoing work is quite a common term used across the report, and I don't feel that that gives much assurance for the board in terms of timescales for the work going on. And I wondered if there could be some work done around adding in timescales for the work that's already undertaken in relation to that. With regards to the balanced scorecard, which we were asked to look at towards the end of the report, a question around when is the data actually updated and what is the process for reporting on it at the moment? And are those reports something that we can tap into as part of the ongoing reports? Because obviously we would want to capture it when it was current. Thank you.
Okay. Jerry, then Michael.
Thank you, Anne. Yeah, I mean, I like yourself, Anne, I very much welcome this report, and I think it will be the start of a journey towards us understanding a lot more about children's services. Specific question I had on this report related to our performance, if we use that phrase, on the MMR vaccine, and we're at the lower levels. And I would just like to have a general discussion with that, and it's just to understand what we're doing, if anything, and what timeline we have round about that. I probably got quite a few more comments in relation to probably the broader topic area, which I think addresses some of the other questions which Sally has posed to us. It seems to me that the best way forward is to have a programme of reports which cover certain aspects at times of the year, rather than trying to do everything in one report every couple of months, because that will just be impossible for those preparing the reports and probably for us receiving the reports. I think though the bundling up of whatever the performance measures has to be thought about, so that we've got a coherent bundle at each meeting. So we're almost topic specific, and that might allow us then to actually invite the proper people into the room to actually engage in the discussion and actually get below the information, because I think some of the discussion about CAMS told us that we probably we need someone who needs a lot of information about CAMS to actually tell us that. I think the key word for me is an integrated system, and so I think we do need the information about the services commissioned by NHS Highland from Highland Council needs to incorporate into this. And I have written down, as I've been sitting here today, I think the third sector to get that involved would be good as well. And I'm thinking about child poverty as well. I think we've got all these issues, but these are longer term. I suspect only then will we start to get a fully system-wide coverage there to see if it's all telling us the same sort of things. But I think the inclusion of the commission services for this committee is important, because I was looking at 5.4, our terms of reference. Our obligation as a committee is to provide assurance on the performance of commissioned services as well. So at the moment we're not providing that assurance, the board. So we have to get there. But I strongly welcome the direction of travel, and just picking up Joanna's point as well. I picked up the thing. I think if it is a performance report, it is, so therefore it is data for performance. It is not a public health report telling us what's going on. It's a performance report. This is what we're doing. this is what we're doing to increase performance or maintain performance. These are the challenges, these are the timescales, these are the risks. I think we have to get into that sort of, and again, that's a development down the line where we need to understand that, because we need to understand whether an MMR is a really good example of that. Is that poor performance, or somewhere actually as a board we're comfortable being because for whatever reasons, and so it's a good example of that. But I think the biggest thing for me is to actually have them bundled up at 4 meetings a year will be tremendous, and then actually have the people in the room where we can actually have the questions and have the local authority data in there as well. To me, it's actually a must do. Thank you, Anne.
Okay, Michael, and then I'll come back to Sally.
You know, as this is an assurance committee, think this has raised more questions than answers. I've not been assured by the I know it's very complex. I've not been assured by the discussions. I'm not sure whether the Mari's had her question answered and where that might be going. I'm concerned, as Sally refers to threads, there isn't a connection here. And I'm just wondering, obviously, whether it's needed to have a round table meeting of all the organisations connected to this. But I said at the beginning, it's raised more questions in my head than answers. I think probably the other thing, as far as young people, I was speaking to a friend of mine last night who's got a 13-year-old son. Now, young people are much more aware of news now than when I was a kid. You know, we just saw the 6 o'clock news, probably didn't take any notice of it. And he said to his mother the other day, are we going to get bombed? You know, and there's a lot of emotion at the moment. And I'm concerned that a lot of young people now are far more aware of the world than when I was a kid. And I think it could be something that's just coming over the horizon.
Okay, before I ask you to comment, Sally, and I see Louise wants to come in. Maybe I'll ask Louise to speak first, but can I just ask you to clarify one thing? Is the intention that this format of report, either as you have here, a bundle of a subset of the full list or the full list, depending on what we decide, is this intended as an addition to the kind of report, for example, that Jane Park has submitted to the committee in recent times, going into in some detail the performance of the council in terms of the commission services, or is it intended as a substitute for that? Can you just clarify that first of all before I ask, before we see what Louise wanted to come in with?
Thanks, Anne. So I think I'm looking for a steer from the committee actually in terms of what they're wanting for, and I've got a clear message around assurance. I happen to think that the public health context is really important for children, because we're not just doing things at that point to meet that need. That need is in the context of their lives, their school life, their family life, and it's part of the life course approach that is really important for children. We're investing in health and well-being from 0 to 18 that plays out through your 30s, 40s, 50s, 60s, and in many ways your first 1001 days can be mirrored in your last 1001 days, particularly where there's been a lot of things to make sense of. So our early deaths, premature deaths, be it through suicide, drug-related deaths, are often informed by those earlier experiences. So I hope that's helpful. There is a tension, I think, between scrutiny of the services in the council, but also an equal interest in what the Health and Social Care Partnership and acute part of NHS Highland deliver on, and that it is part of the narrative for children's experiences of healthcare. And I happen to think it's important to look at healthcare before we do the integrated bit, because if we're clear ourselves what we're doing, we're better placed to go to that broader table. So I think that I've heard a clearer message around assurance. I absolutely get the message around performance. It's not really a performance report at this point, partly because of timescales and partly because in any performance report you need quite a lot of time to get the prep in, you need your data out, you need your analysts to look at it. We've clearly got some work to do to make it more standardised and more legible for colleagues, if that's okay. And I think there is an outstanding question around where the assurance for Highland Council service sits, other than I'm aware of perhaps a different narrative that says we should be looking at things in the round to understand the totality of our system. So those are my thoughts at this point.
Okay. Well, I'm sure there are a lot of discussions about where it should sit, but at the moment it sits under our remit. So, you know, I think that's the issue, that we may be talking about it sitting elsewhere, but for the moment it sits with us. Anyway, Louise, did you want to make a comment?
Yeah, absolutely. And I think I'm in this similar place to a lot of people in that this is the beginning of our journey to get this right, certainly not the end. And I think following on from this, we need further conversations with council colleagues, Jane, Fiona Duncan, Sally, myself and others, but also our acute colleagues, because obviously, as I say, the complexity here is that CAM sits within the acute structure, although we're very clear that it needs to be integrated with everything else we do. So I think there's further work for us to do outside of here to understand exactly what we're bringing forward for future meetings in relation to that understanding and assurance of the services that are covered within the remit.
Okay, so I think, Sally, I've heard some key messages that whatever format the report ends up as, it has to help us fulfil our terms of reference in terms of the assurance to the board on the council commission. Either that or our terms of reference have to be changed. I think there's also support for not covering all the measures in one go, but chunking them up, provided they're chunked up in a sensible order, and the right people are in the room at the right time to discuss them. And then I think there's been some broader messages about the system, the wider system, the importance of the inclusion of the third sector in any discussions about that, the importance of young people's participation in designing our response to issues, which probably sit more in the integrated children's services structures. To answer Michael's question about where will it go, you gave I think it was pretty clear. You were saying that's where those sorts of issues need to be fed in and addressed. So I think does that give you quite a good flavour to go away and get us on the next part of the journey?
Yeah,
Louise, do you want?
Yeah.
Louise, do you want to add anything before?
Yeah, apologies. I just wanted to say, Mary, it might be useful to catch up out with the meeting and just ensure that we're linking in correctly with the right people so that we can have that conversation about third sector involvement. Happy to do that.
Okay, so Sally, is that sufficient for your needs for the moment?
Yeah, I think it is, and just to provide assurance around the young people, that there is a previously we've worked with young people through Inspiring Voices to support recruitment into CAMS, and we've picked those discussions up again. So there's a link there that used to be known as Highlands Children Forum. So we are making some of those joins, but I'm more than happy to pick the conversation up with Louise and colleagues as to how we frame future performance reports and also where the responsibilities for bringing those together sits. So I've stepped in from a professional Child Health Commissioner role here. It may well be it sits better from a performance within the operational services. More than happy for that, but we can pick that up and come back. Thank you.
Well, I mean, there are, there might be other options. For example, that we take a more of a public health overview once a year, and with more performance focused reports in between time or whatever. Okay, so well, I think that was well, we had that prompted quite a lot of discussion, as I was sure it would do. So thanks to everybody for your contributions, and to Sally for taking the initiative and sending us off on this journey. And I look forward to a report on progress with it, Louise, in your next Chief Officer's report or whatever. Okay, so I think we're on to the Chief Officer's report then, Louise.
We are indeed, and as ever conscious of time, I'm not going to go over too much, but I just wanted to make some key points, and then happy to take questions on the rest of the report. You'll see at the beginning of the report there's details and updates on a number of projects across various different parts of Highland. Good news is obviously that the new hospital in Skye, patients will be moving into it literally in the next week, and that's really good to see. We're getting that service up and running, we're getting all the services established there, and we have tried to learn from any teething problems in Aviemore so that we can make this as seamless as possible, but equally we know nothing is totally seamless when you open a new hospital, so we're expecting challenges along the way. And also the good news is we have had government approval for the initial agreement in relation to Caithness, so we will be starting work on that redesigned business case. It's also worth saying that although a lot of that update is very much building focused, we are very clear that all of the service redesigns need to be about the whole system, the whole community, and there may not be a huge amount of detail in there about some of that work, because a lot of it will be linked to our new strategic work that Tara has spoken to us previously about in terms of how we develop the local service provision. So we've already started some of that work in Caithness, in Skye, Loch Arbour. We're establishing that in other areas, the North Coast and Sutherland, etc. So we will keep updating on that progress as we go ahead. In terms of adult social care, I think it's just important to note that the integration scheme, which was submitted to the Scottish Government last year, has been approved literally last week. So we are in a positive position in relation to that. There's some details there about new funding that we've received in terms of social work teams, which is really positive news and really good for the teams, the integrated teams and the social workers. I would give the caveat that, as with every other pocket of money, it's given to everybody in Scotland, so we will be competing for that recruitment challenge. There is also details about uplift to carers monies, particularly in relation to direct payments, which is good news, and that is for this year and next year. So one of those that we've got clarity on for the next year. A lot of detail there about care homes and care at home. Both areas are under significant pressure. Today, for example, the care homes, we've got 30 closed to admissions, which is almost close to half of our care homes. 7 of those are in full outbreak status, so that's quite significant, and we have been higher than that. We have been, close to 40 on those numbers. And just finally, the other one I wanted to highlight there is the details of the Alcohol and Drug Partnership annual report. We didn't bring the annual report here in full, as it had been elsewhere for approval, but we felt it was appropriate to give a summary of the report in relation to this committee. So happy to take any questions or comments.
Okay. Michelle.
Hi, thanks very much. I've got a couple of questions for 2 different areas in this report. The first one is the strengthening of the social work teams. I see that you've been given additional funding for 18.3 WTE social workers for North Highland. And in the January meeting, looking back, there was additional funding made available to recruit 47 new healthcare support workers across North Highland. What I was just wondering is, what do you think the chances are of recruiting to the social work roles are? And with additional money given to employ the extra 47 social workers, do you think that you'll be able to achieve this? And if not, are there any thoughts about the different types of roles within the multidisciplinary team which might give a better outcome going forward? And my next question is regarding the care at home commissions provision. I was a little confused with the first two paragraphs over your dates and COVID outbreaks, but I've kind of broken it down, I think, to see that to 14th of February, there was 25 confirmed outbreaks to 69 care homes, which was reduced to 10 at the time of the paper being produced. On the 9th of January, you had 47, which you've just confirmed is reduced to 30 of the 69 care homes closed. So that's quite a decrease. There's a decrease in COVID cases, but an increase in care home closures. So I expect some of this is probably related to staff shortages through self-isolation. But are there going to be any long-term implications for these closures? And also, do we know at all how many empty beds there are across the whole of the 69 care homes? And how many people are waiting in hospital for a care package currently? Thank you.
Okay, Louise, do you want to?
Okay, super, thank you. I'll try and go through those, and if I don't capture everything, Michelle, apologies, I'll come back to you. So if we take the point in relation to social workers, we are realistic about recruitment into that many social workers because we know it'll be a challenge. We also know that we have a particular challenge that because we are employing social workers as a health board, that in itself makes recruitment a little bit more challenging because we have to try and target people more. They're not necessarily looking at an NHS website to find posts. So that is something that we are very mindful of and we have to particularly focus on. So the challenge is as well that sometimes money is given with a specific ask, i.e. you have to recruit X, and there isn't a huge amount of flexibility to say we've been given money for social workers so we'll recruit OTs. That sometimes is a problem that we have to go back to Scottish Government and talk about if we absolutely can't recruit to what the ask is. Some of the post monies that were referred to were for support workers, and clearly we are always more hopeful of recruiting support workers because there isn't that we can provide the training that people need as opposed to them having to have the qualification. So always with support workers there is much more of a hopeful picture. So I'm cautiously optimistic we will do some recruitment. Whether we'll get it to the level we want is tricky. So I think that's probably fair to say. In terms of care homes, that it is very much a changing picture from day to day as to which care homes are closed, which aren't. It is sometimes related to staff who are COVID positive, so as a precaution the home is closed. It's sometimes residents, it's sometimes both. Occasionally it will be because there are quality challenges or other aspects that it's not an appropriate place for admission. That's in the minority of cases where we don't admit for those reasons. In terms of number of care home beds available, again, that's a moving feast from day to day because if a care home's closed to admission, we can't admit, so those bed numbers go up and down. There are always beds within the system, but often they're not in the right place. So at the moment, my understanding is that we've got 30 people waiting in hospital for care homes. We've got a similar number for waiting for care at home packages, slightly more, I think, which is actually somewhat of a bigger challenge. So some of the work we're doing now is really trying to match those beds with those people and try and move people through. But the delayed discharges is a real issue for us. And it's not going to get much easier because even if a care home's open to admissions, the care home may not feel able to admit because of their staffing position. If they haven't got enough staff, they're very anxious about taking in more residents, particularly with mindful that care inspectorate can be quite critical if they take in too many people when they haven't got the capacity. So that is a real ongoing and live challenge for us, and one that we're working with the care home and care at home sector to try and support. In terms of care at home, some of that is in-house. We provide our own care at home services in some areas. In others, it's other providers. We are getting packages handed back to us because, again, that recruitment challenge, people can earn more money in professions that aren't necessarily as challenging as being a care at home worker. So it is a difficult position. Have I answered all of your questions, Michelle, or was the one in the middle I missed?
Sorry. Yeah, somebody was at the door, so I had to go and ask them to go away again. So I missed bit, but I've recorded it. So I'll listen back and have a listen. I'll get back in touch with you with any further questions. Thank you so much.
No problem. I don't know whether Ian wants to come in on some to add to what I've said.
Ian?
Yeah, it was really just a little bit of detail. So, Michelle, I think it was a good question about the 18 or so social workers, and I think you're right to identify that we might not be able to recruit to those immediately. However, I'm sitting as the chair of the Social Work Advisory Committee, so we got some quite interesting news. There was 2 trainee social work posts that were advertised. So that was positions whereby people can come along, get trained and kind of learn on the job, if you like. So it's a little bit akin to a kind of apprentice social worker. And there was 2 posts offered, for which we got over 50 applicants for those posts. So that was quite wow, actually, I thought. And so although we might not be able to immediately recruit, I think that money is ongoing. And I think also there's been quite a bit of workforce planning within social work. Well, I know there has been. I've been working with one of our professional leads, Ruth McDonald, on that. So although we might not just be able to pick 18 social workers off the shelf, I think that's very unlikely. I think we will be able to plan and start putting plans in place to strengthen our learning and development and our ability to take folk who are in Highland, who live in Highland, and translate those. Obviously, there's a great deal of interest with that 50 applicants into social workers. So it's not quite now, but I think we can. I think that money can still translate in the fullness of time and through training into social workers. So I was really encouraged by that number. I was actually, I was quite gobsmacked, but in a pleasant sort of way.
Just for context, Ian, what is the current establishment of social workers? You know,
That's
I'm
a good
trying to get...
question, Anne, but I think it's around about 88 or 89.
Okay.
That now somebody might come back and tell me I'm wrong, but I think that's about right. Yeah. Okay, Michael, you were next. So I see Danellen's putting her thumbs up, so you're obviously got that about right, Ian. So Michael next, and then I've got Wendy.
Okay. Yeah, I wonder, Louise, if you could tell me what the current status of the North Coast redesign is.
Absolutely, Michael. So in terms of the physical building, the plans are being drawn up and developed in relation to the building itself. However, we know that the redesign needs to be about that wider, what is the service as a whole. And that's what I referred to when I said that we are looking at how we establish new models of working. So we're taking into consideration what we've done in Caithness in terms of that whole system redesign. It's at its early stages because we've had lots of other challenges going on. So I don't think we've progressed as much as we'd like to in the North Coast. But it is certainly one of the areas that's on the radar and that we are going to be taking forward over the coming months.
Right, okay, can I come back to this, Anne? This is the 7th year, the North Coast, this is the 7th year that North Coast redesign has been going. And we had a meeting on last Thursday, and it was good news for the hub. And Michelle Johnston agreed that at the next meeting on May the 26th, there will be a framework, timetable and a schedule for the plans for the hub, and also for community engagement in regard to explaining what the hub's there for, what the plans are and that sort of thing. That was agreed that to happen on May 26th. However, there was no discussion about the redesign. As you just said, Caithness has got government approval for the redesign there. We discussed nothing about the redesign. There was nothing about future plans. It was all in the pipeline. And I think we just recently had a report that the Teignmouth District Medical Group, who took over the medical practice at Tongue last April, will be leaving the contract on the 1st of May. So that means the provision's all up in the air again. That'll obviously mean locums, which is, I don't mean to be pejorative in this, but that's better than nothing. But the problem with locums is that I've had experience with myself, is one locum contradicts another sometimes. And it's not, it is not a continuity of care is probably the best way to put it. Now, a few years ago, we were talking about nurse practitioners probably taking this over and that sort of thing. So what I'm looking for is, I feel at the moment the North Coast redesign is under the radar, not on the radar. And what I would like to see at the next meeting in May the 26th, some sort of framework, some sort of intention of how this is going to work, what the plans are. And I just feel, because, as I said, this is the 7th year, that we're way behind other redesigns, and I haven't had a coherent explanation from anybody. In fact, I've had 3 senior managers over the years apologise to me about this, and I just want to have some confirmation of intent and how this is going to be dealt with, who's going to be running it, and when the community from Melvick to Lochinver get a chance to have a comment and a discussion on the health service that, as far as I'm concerned, is equality of provision.
Louise?
Yep, absolutely. Thanks, Michael. And I will pick up with Michelle in terms of what's happening about that wider conversation. I have had discussions only this morning about the primary care provision, because obviously with the situation as you referred to in Tongue, and the primary care managers are actively looking at what model would be appropriate for there, because clearly it's going to become one of our practices in the short term, and possibly that we need to acknowledge in the medium term that would be, if we plan for the future of it being ours rather than it keep going from pillar to post, it may be the pragmatic best way to do it. And certainly we have, and again, I hate to refer to another area, but we have quite successfully done some change around primary care in Caithness that will be a good marker for other areas. So I think there are some ideas, but they're at an early stage, and I will ask Jill from the primary care, who's the head of primary care, to ensure that we have those dialogues with the local community and with Michelle about that wider service redesign.
Okay. I just wonder, Louise, whether I mean, it looks like there's a capacity issue here in terms of moving those discussions forward. And I just wonder if there's any way of drawing on or linking up with the resources that we have for Together We Care strategy development. At the moment, there's obviously a lot of work going into community engagement and, meetings and things around that. I just wonder whether it might be possible to draw on any of those resources to help have some local discussions about this, redesign in Northwest Sutherland.
Yeah,
don't
absolutely.
know, just a thought.
Yeah, no, it makes absolute sense.
Okay, so, and just to broaden Michael's point out, last year, not earlier this year, last year, we obviously had a report at this committee from Rhiannon about the enhanced community services pilot and the wider, and the other areas where we were having a look at things. And the issue about equity and everything was raised then. So I think at some point in our work plan in the sort of early part of next year, perhaps it would, and this may be linked to Tara's work, I don't know, it would be good to get a picture of exactly how those are doing and how we're going to roll those discussions out more broadly across the patch, if you think that would be reasonable.
Yeah, absolutely. And certainly within some of the new monies, there is an opportunity to look at MDT working and new money in relation to that, which is always positive. So that's something certainly Elaine and I have been in discussions about.
Okay. So, right, Michael, well, if we don't make progress on that front, I'm sure we'll hear about that at our future meetings from yourself. So Louise is obviously now, making a commitment to try and move that forward. Wendy?
Yeah. Thanks very much. I can confirm your view.
Yeah. Wendy?
Thank you, Chair. I've listened to I've listened to the reason given for care packages being a barrier, possibly as long as I've been in Highlands, actually, coming up for 3 years. And I wondered what plans do we have to try and mitigate this for people that are waiting to be discharged from hospital. I do know that the Scottish Government some time ago, last year, increased the hourly rate, but when that doesn't actually drill down into paying the carer very much at all. It's gone from £9.50 to £10.50, and I think that somebody has already said that some of the work is very very challenging, and people are able to earn more money by doing other jobs. I was wondering, taking into account the national plan for the National Care Service, about even on a temporary pay basis, NHS Highland actually recruiting and employing their own carers, healthcare assistants, whether that would help improve the situation.
Well, of course, we have a mixed economy whereby we do employ people directly in the more rural parts of our patch, but we commission independent sector providers to provide the care in the more populous areas of the patch. But I remember that in the last Chief Officer's report, I think there was information about some additional funding that we'd got to employ. I think it was 28 or 29 additional health and social care assistants. So maybe, well, hopefully we've made some progress with that. But who would like to pick up Wendy's question about how we're trying to address the challenges of delivering extra care at home capacity?
Thanks. I'm happy to pick it up, and
okay,
if anybody,
Louise.
anyone else from the team wants to come in, they're most welcome. You're right, Wendy. It is a big challenge, and it's an ongoing one that I'm sure we'll sadly revisit for a while. Yes, the money did go up. It's gone up twice, but again, it doesn't feel like it's a big jump. That's the reality of the payments that the Scottish Government have given us. And as Anne rightly says, we do have a mixed economy where we already have our own in-house care at home staff. We are still challenged in the areas where we've got our own in-house care at home staff. And certainly it's interesting, I was talking to somebody in one of the hospitals in trying to remember where I was. I think it might have been in Golspie the other week, and they were actually saying they used to work in care at home, but the huge drive between each of the people they cared for was very prohibitive. They just got fed up with it, and they preferred working in a hospital setting. So there's all sorts of reasons why we lose staff from care at home, which is really tricky. And it is that people often will start off with care at home and then they will move to somewhere else, or they will just have enough of that role. So we've got to try and see if there's anything different we can do with the role to make it more interesting too, because that is its own challenge. But certainly in terms of what we're doing, we are exploring whether there's a scope for us to put in some form of incentive payments, particularly to providers if we want them to increase their capacity for providing care at home. But we need to be mindful of how we do that and what we offer, because it's got to be done in a sort of a way that we can financially manage, but equally is fair. We are also looking at whether we do increase the amount of people that we provide, that we employ in-house rather than third sector or other agencies, and also looking at that option of do we block contract much more. So we do to a degree, but block contract is much better for the providers, because that means they've got a safer income coming in rather than spot purchasing. So that's again been something we've been trying to explore and look at how we do that. So there's a number of areas we are taking forward, but we equally know that it is a difficult challenge and it's not an easy place to work. And I think Gillian may want to come in and say some more sensible words than I have done as well.
Gillian?
Chair, thank you. Yeah, I just wanted to come in just to update on some of the practical discussions we've been having with the care at home sector. and they've been particularly since August last year, where we've been having strategic discussions with the sector as a whole. So that's all 20 independent sector providers in Highland. And those meetings have become more frequent over the last few weeks and pre-Christmas. And what we're most recently looking to understand and clarify is what tangible actions will make a difference. So we're now very aware of what all the issues are, all the barriers that there are to recruiting and retaining staff in a really challenging role. And last week and next week we have a facilitated workshop discussion with all of those providers around, what are the 3 to 6 month actions that would make a difference in order to relieve capacity, build resilience, etc. So those discussions are very live. Louise had provided some examples of some of the contractual provisions that we might be considering. There's other practical things around the start time of a care at home worker shift, and whether or not a 7 AM start is prohibitive to people who have got young children or caring responsibilities, etc. So nothing's really off the table at the moment. We're looking at everything with the people who know that sector and market best, which are the people who are providing the services there just now. So hopefully that provides some further reassurance.
Ian, and then Dunellen.
Yeah, just a quick point. I mean, I think oftentimes it has to be an option 3 for people who are leaving hospital, but not every time. So as part of the SDS strategy consultation, we've heard quite a bit from managers of an option 1, people who employ personal assistants and manage a direct payment around about what the level of that needs to be to be attractive, particularly in the most rural and remote areas. So we're looking at that, actively looking at option 1s and the rate for that as well. It won't be a panacea, but it might help around the margins if we can come up with something that is more attractive and maybe provide a little bit of provision in places where there's very little.
Dunellen.
And it was just to say, finally, excuse me, the recruitment to the additional posts is ongoing, and we have had a lot of interest. I don't have actual numbers to my hand, but it's very much ongoing. Lots of interest and strengthening. We're recruiting through the CRT, but that is a North Highland approach. And we are also have got staff from Highland Council who have indicated an interest to work with us. So we are looking at employing them as well. And again, good geographical coverage. So as you see, Anne, it is very much a mixed economy. But the additional posts that we are taking on, we'd be very much wanting. We're absolutely focused on mutual aid in terms of COVID at the moment, but moving forward, we are wanting to be focusing that team on recovery and rapid response, so that we're very keen to have teams that we can mobilise at short notice in terms of preventing inappropriate admissions and supporting timely discharges.
Okay, thanks, Dunellen. Ian, can I just ask for, you mentioned a subject dear to my heart, which is personal assistance and the rate of pay for the rate for direct payments. Can I ask if the rate is going to allow the payment of £10.50 to?
I don't specifically know that. There's a group of folk, and one of whom was a kind of main mover and shaker in our reference group for the SDS strategy in Fort William, who there's now a group of people who manage option 1s who have come together. I think they're largely carers. So myself and James Bain, who works in resources with us, we're going to have a discussion with those guys and just try to understand where we're at. So they were quite keen to talk to us around about, what actually our option 1 rate does get, what it can mean for people. I think it might be different in different circumstances, Anne, and it's actually ultimately around about the employer themselves, how they choose to pay individuals. But I suppose it's about what the opportunities would be and what are the opportunities that our rate currently offers and what would be necessary for us to, I suppose, have more option 1s. So we're at the beginning of a dialogue, but that's with people who are actually trying to manage these sometimes quite big packages. quite a number of hours and trying to have a kind of, I suppose, an open discussion around about where the challenges lie and see if we can move it forward. So I guess I don't know quite what the answer from all of that will be, but we're happy to have the discussion, and I think that we recognise that at least part of the solution has to be option ones, particularly in a world where the recruitment of staff in care at home and care homes is really difficult. So how do we do it more flexibly? How can we try to do something around the margins? So we're open for the discussion. Don't quite know the answer.
Okay, that's great. Louise, do you want to come back?
Yeah, it was just briefly to add to what Danellen said about the recruiting to the COVID response team. The reason we've done that is because that has proved to be a very successful team, and people are interested in working in it. So as we progress, we're hoping to move that into what we would be calling a community response team with the same ethos and principles and that flexibility. And actually the team, I think, Jackie can correct me if I'm wrong, or other colleagues, I think the team enjoy the variety of the role. It's a challenge, it's difficult, but that variety of working in the care homes, care at home, and sometimes the hospital is interesting for people. So again, when I mentioned that, going back to making roles interesting, it's that doing something that people are saying is a positive and doing more of it.
Okay, thanks. Wendy, do you think that's a reasonable response to your question, or do you want to come back on anything? You still with us, Wendy?
Can't see her.
No. Okay.
There. No.
Maybe we've lost her temporarily. Okay, right. So thank you. Then I think that was a good discussion, and it brings us neatly on to item 3.7, because many of the issues that we've just been focusing on there are perhaps relevant to our next paper. So Louise, who's speaking to this?
I'm going to start off, but I think other colleagues will come in as the detail emerges, because they're much more cited on it than me. Is that sound okay, Gillian and Rhiannon? Absolutely, thank you. So this has been a bit of a long-standing challenge for us, really, in that we did previously have a finance and performance subcommittee that these fees went to on an annual basis for approval. In the absence of that, there has been a bit of a to and fro and void as to where fee approval should go. So what we've brought to this meeting is the first paper talks very much about the fact that at the moment we can't confirm fee rates because we're still waiting for Scottish Government to come back to us in relation to what those should look like. However, what we are proposing is that either it's accepted that those will be signed off out with the meeting by a couple of us, but we probably think the preferred option is to either have a one item health and social care committee or a one item health and social care committee subgroup, which does add complexity because we then have to work out what the subgroup was. Pragmatically, that might not be the answer. So it is really to ask the committee which of those options would be preferable. That's in relation to some of the fees. The other aspect is that the third sector fees, you will see an appendix to the report. The third sector fees have, up until this point, been signed off at the third sector group, which is chaired by Rhiannon. Now, in previous years, it's come from there to here, really for that final sign off and check in. So what we were going to suggest for this year, and again, this is open to the conversation, is that the next third sector group is on the 17th of March. And that group would have a sign off of the proposal going forward, which we're hoping will have an uplift to third sector fees, and would come to the April group for that final ratification. So those are the two aspects we wanted to check with the group. I don't know whether Gillian, you want to add some more to what I've said, or have I covered it?
Chair, if I may, just to highlight the time sensitivities around the need to make sure that we've got contract continuation, so in terms of, I guess, organisational risk, but also in terms of what government are keen to make sure that we have sustainable arrangements in place with those organisations that have commissioned services. And obviously in the earlier discussion, the committee has heard about the extenuating circumstances that adult social care providers continue to work in, and so we don't want this other issue to be of another significant concern to them. So it's always been our position in Highland to seek to confirm the arrangements by the end of March, where that is at all possible, recognising that there's some areas out with our control in terms of waiting to get the National Care contract notification, as well as other arrangements from Scottish Government, particularly around the £10.50 and the National Insurance Plus on costs. So the time sensitivity is really crucial from our point of view, which is why the timing of this next meeting is a bit later than we would wish, in order to come back and seek approval for fees. So really, provider sustainability and time sensitivity key issues just to highlight as well. Thank you.
Okay. Does anybody else on the committee have any questions? So can I just clarify, Louise, first of all, are you saying, because I'm afraid I've got obviously some of these the appendix came late. Are you saying that there's been an update to this paper since it was issued, or are you proposing a slightly amended recommendation to the ones that are in the paper? So the recommendation is now either we have a one-item meeting of the committee, or we have a one-item meeting of a subcommittee of the committee. Is that, have we amended the recommendations that were in the paper? Is that what you're proposing?
I think pragmatically we've suggested a subcommittee in the paper, but to be fair, the more I think about it, I do worry about the timing of being able to do that quickly. Given that we don't currently have a subcommittee, we would have to invent one, if you like, and design who should be on that. So I think it could be a challenge, but equally I'd welcome a discussion as to which. So yes, it is an amendment from what's in the paper, because on reflection, I do think it might be quite tricky to achieve a subgroup in a quick time.
Okay. Any comments or questions? So, okay, Jenny.
I think it's a comment, and I would just to say I welcome what Louise is suggesting. I think it should be a single item of this committee, because I think when we originally raised this issue, if memory is correct, it was about the potential reputational damage issue to the board if in the very unlikely event that we made a total mess of actually setting the fee levels. It's important that there was actually a very strong oversight, and it's an actual as many board members as possible through the committee involved in the decision, so that we could actually do that. So I think actually an amended recommendation that we have a single item meeting of this committee, I'm totally in favour of that. With the appropriate support from the fees group, with a paper that actually outlines the basis for any recommendation, particularly where it veers away from Scottish Government guidance, which I suspect would be few and far between. Thank you.
Okay, Michael.
Yeah, I'm just wondering, the next meeting of this committee is the 22nd of April. Is there a decision needed before then?
Yes.
Right. Okay. Then we'd better get on and do it then, hadn't we?
Okay, so partly because I certainly my own preference is that we have a single item meeting of this committee at whatever timing is required to meet to meet the concerns that have been raised about provider confidence, etc. So my question is, do we know just now, Gillian, when we need to set that, by what date that meeting will need to take place, or are we still waiting for information that would allow us to set the date?
Yes, we're still waiting for information about that date. The experience of the last couple of years has been that that's often quite last minute and rushed. We have no control over that. We are just kind of waiting to react. I am aware that there were discussions with Scottish Government about mandates, etc., towards the end of last week. But really, we're in a reactive position, I'm afraid.
Okay. So what I suggest is that we start that's what we agree, that we are going to have a single item meeting of the committee, and we start immediately after, we start now after the meeting today, looking at what the quorum is for the committee, and who would be required, if it's for the minimum number of people to be present for the committee meeting to go ahead. And start working on that now, so that there aren't any problems in actually having a committee meeting. I suggest that, well, Louise, I'm just thinking, should we agree that that is the preferred option, to have a single item meeting of the committee, but that if that proves impossible, then we agree that the specific issues about the fees for care at home and care homes can be agreed by the delegation that's set out here at 4A. Would that be an acceptable, is that an acceptable position for the committee members and for the officers? Jerry, are you happy with that? For this year only, I'm proposing, and that we revisit the longer term situation. So I'm basically
I would
saying,
suggest a
let's
slight
agree
amendment to that, and if possible, that actually, if we couldn't get a meeting of the committee together, the delegated group would include yourself to represent the group, if that was possible.
Okay, Louise, is that acceptable? Do you think?
Yeah, absolutely, and it may well be that we can get a date in the diary, but significantly fewer people can attend, which is still reasonable in its own right, I think.
Okay, so basically the recommendation would be, well, or the decision would be that for this year we are going to have a single item meeting of the committee to agree these fees. If that's not possible, then it will be mandated to the group referred to in the paper, in consultation with myself. So I have a lot. So in terms of the longer term and going forward, there's quite a lot of questions I would like to ask about the proposed remit of the group. So I would ask that we don't agree anything today about the arrangements or the remit of the fees group going forward beyond the immediate decision for this year, because I'd like to discuss that further out with the committee, with some of the officers involved, before we bring that back. And in terms of third sector activity, Louise, to be honest, I haven't actually had time to read the appendix that was circulated, so I would have no idea what I was agreeing to or not. So can you remind me what you were asking us to agree about, the third sector in particular?
Yeah, absolutely. It was at the third sector meeting in March. We'll look at any proposals for a slight increase in third sector fees, and that would come to the April meeting. Can I just double check that's right, isn't it, Rhiannon?
So the paper is an update on the activity that's ongoing at the end of this financial year, which is around the tendering processes which are ongoing for the over 50,000 bids. So it's just here for information. But Louise and I have discussed what the process would be for looking for an uplift into that pot of money, and I think that's where Louise is looking for that process.
Okay, so can we would the decision whether or not to uplift that pot of money not be one of the decisions that would be taken in the single item meeting or by the delegated mandate if the single item meeting, I mean,
if
doesn't
the
happen?
timing's fit with the 17th of March, which Rhiannon's got the third sector group, if the timing's fit, which they may well do, I think we could look at both.
Okay, well, if the timing's fit, then I suggest we look at both together. If the timings don't fit, then, well, I think, I mean, Louise, I have to say that given the recent situation with one of the organisations that's part of that group of third sector contracts, personally, I think there's a need to have some sort of consideration at the committee of how all that process is going in April. In any case, to be honest, is there any indication, Louise, as to whether or not it's likely that we will be proposing an uplift to that pot of money? Yes, we will. Okay, well, on that basis, then I'm happy to agree that that we do it. If it's not possible to include in the single item meeting, that it's done at that third sector meeting in March, and then a report brought to the April committee, which includes, what is actually happening with all of those contracts. Is that acceptable, Louise? Is that okay?
Yeah, absolutely. Thanks.
Right. Okay, so I hope Stephen's clear what's happening there, but I think we've come to an acceptable position for this year, and after further discussion we can come back to what's happening in future. Okay, move on, Louise. Yeah, you happy with that? Right. Okay, so we come on then to the final items for committee function administration. So we had in the papers a draft of our work plan for the coming year. This is obviously something that does, is adjusted as we go through the year, because inevitably some things don't come in the order that we plan So did anybody have any comments or additions or suggestions in relation to the work plan? Don't see anybody. So are you happy to approve it? Yep. Oh, Ian, did you want to come in? Sorry.
Yeah, sorry, I was just wondering around about what the content for, there was a proposal for an Adult Protection Committee annual report, and I guess just wanted a little clarity what the expectation was for that in April.
So I think that was a suggestion that this committee should consider the annual report of the Adult Protection Committee.
Okay, I think there's a biennial report that's provided, but I'll go back and check that. But off the top of my head, I thought that that was the case. But I'll go and see. Is that looking at a report that's already been prepared? And was that the kind of understanding? Sorry, maybe Louise is the answer.
Well, I think that the issue, Ian, was that the committee considered it should be better cited on matters related to adult protection and the work of the Adult Protection Committee. So, well, that's what I think that refers to. So okay. The expectation was that committee produced some sort of report of its activities and its view of the state of adult protection in the area, but perhaps that's not.
Well, as I understand,
the case.
Well, it may well be the case. I guess I would wonder in terms of reporting. I understand that the Adult Protection Committee reports to the Highland Public Protection Chief Officers Group, and that it provides reports of its work there. So
Louise? Louise, do you want to come in?
Yeah, absolutely. And I suppose, Ian, we perhaps need to go into the detail offline, but I think as it fits within the wider remit of the assurance here, it seemed to have that crossover. So I do think it's something we probably need to explore in more detail what's in that, but I think it would be a helpful thing to come to this meeting.
Okay.
So it might not necessarily be as described there, Ian, but this arose from a number of chief officer reports where concern was expressed about rising numbers of adult protection investigations that social work are being asked to undertake, obviously capacity issues, and I think the committee felt that it needed a deeper dive into, to these issues to get assurance about what we are doing, in terms of adult protection. So however you want to do that, whether there's an already existing report that can come that would allow us to see the state of play, or whether it would require some other work. And if it requires other work, if it's not possible to get it together for April, then obviously we can consider that being moved to another date.
Okay, I'm happy to take that offline and think around about it, and just where the respective governance lines sit, because I think it's important that we don't want to kind of get cross wires, because the Adult Protection Committee has its own statutory function, and I guess that's in large part what it's there to do, is to try to make sure that the adult protection work is discharged across Highland. But yeah, happy to pick that up offline. Okay, thanks.
Okay, right. Any other points, Louise?
Yeah, I think just to add to that, Ian, it's just how we work out that crossover between this committee and that, in terms of that interrelationship, if you like, because some of the things that we are absolutely required to cover interrelate with that adult support and protection work. So it's maybe the relationship, but for example, around our social work availability, all of those things that we maybe look at as assurances here. So we can look at that offline. And the other one, just Anne, is to just make sure that we move the learning disability one from this month to next month, but that's fine.
I didn't want to give a commitment to put it into April without discussion with Arlene, Louise, and, you know, it may be that some of the further work that she might have been reporting on to the committee, you know, it might be better to wait until another committee meeting until that's happened. I don't know. So I wasn't committing us to, obviously the sooner the better, but that needs to be added in here somewhere. Absolutely.
Yeah, because it's a busy agenda in April anyway, isn't
Yeah,
it? So,
well, that's what I was concerned about, to be honest. Okay, so are you happy to approve that then? Yep, okay, thank you. So the next item is the annual assurance report, which is, as it says, an annual requirement. You have the draft before you. Does anybody have any questions or comments on that? Don't see any hands up, so can I take it you're happy to approve that? Oh, Neil?
It's only a small comment, just to say that I thought I was here in November. We had quite a discussion around vaccinations, as I recall.
Okay, I'll get Stephen to check that and we'll update it if that's a mistake. Okay, thanks for that. Okay, so with that check, then are we happy to approve it? Thank you. So the next item is a report, just an update from Louise and myself. I think the paper's fairly self-explanatory. Because of all the pressures, it was agreed that we wouldn't undertake a full self-assessment this year. And Louise and I have had a look at the actions and updated them and proposed a new action plan. So the question really is, are you happy with the updated action plan in terms of improvements for the committee, or does anybody have any questions or additions they'd like to see in that? Don't see anybody. Okay, so are you happy to agree that then? Thank you. And the final item on the agenda is a very simple update to the terms of reference, and that's following feedback from our lay representatives to change the name of their place on the committee to independent lay members. Are you happy to approve that change? It's just the name, how they're referred to in the terms of reference. There's no change to their role or any of that implied. Happy? Yep. Okay, right, thank you for that. So is there any other items of business? Michael?
I'm just going to say that over the last 5 years, we've had a few nominated councillors on this committee, and coming the elections in May, some of those councillors will be standing down and possibly not returning to this committee. I think it might be a good idea to thank them for their contribution over the 5 years to this committee.
Absolutely would be, Michael, very appropriate. It's my understanding, but somebody can correct me if I'm wrong, that the councillors will continue in post beyond the date of our next committee meeting. Is that correct? I don't know if I noticed that Councillor Fraser had to leave us and Linda obviously submitted her apologies. But that's my understanding, Deirdre. So I was kind of hoping they would be present at the next meeting, but
yeah. We should be. We're in post until the day before the election.
Okay. Well, I absolutely agree with your sentiment, Michael. And no, that's fine.
Jumped the gun.
No, it's a good reminder.
I'll have another go in April.
Yeah, well,
we can do it twice, Michael.
Yeah, there's no harm in doing it twice, and as I say, that as some of them aren't present here today, then we should do it again in April. But obviously, that's absolutely appropriate to mark their very important contribution to the committee. And indeed, if any of them are standing again, to wish them well in the election. But I'll leave that to them to to tell us about next time round. Okay, so and the date of that next meeting is the 27th of April at 1 o'clock. And thanks everybody for your contributions today. And we'll see you then, hopefully.
Thank you very much.
Thanks.
Thanks.
Thanks so much. Thank you.